With Chapter 7, we are back with bone tissue, so we're going to look back at the histology of osseous tissue. So the first part of the chapter, we look at tissues and organs that are involved within the skeletal system. So with Chapter 8, we named the bones and the bone features. Now we're actually breaking it down to the cell and tissue level. We'll get into some of the histological structures that are associated with the osseous tissue. There needs to be a discussion then on the two ways that bone develop. So we'll discuss those two ways. And then finally, we'll talk about some of the physiology that's going on with the osseous or the bone tissue itself. So again, remember the other name for bone tissue, of course, would be ossified or osseous tissue. A lot of people, when they think about the skeleton, well, oh yes, the skeleton's formed there, it forms the solid bones. We've talked about compact versus spongy bone, but a lot of people don't realize that it's a living tissue, just like your skin is a living tissue, just like the organs of your body, the liver, the kidneys, the brain, all of those are dynamic and living tissues. Well, osseous tissue is capable of remodeling throughout your lifetime, so it is considered to be a dynamic and ever-changing tissue. So it has metabolic needs, it undergoes metabolic processes, and it has its own physiology. So remember with osseous tissue that it is a type of connective tissue. So you still need to understand the four major types of tissue were epithelial, muscle, nervous, and then connective was that fourth group. So it was a type of connective tissue. Remember with bone or the ossified tissue, you have the matrix, that extracellular stuff, the matrix that turns from cartilage into a calcified or hard, stony matrix. So the minerals that are brought in this process of mineralization we're going to see allows calcium phosphate compounds to come into the matrix, and the cartilage starts to ossify or turn into bone. The individual bones, of course, have their own tissue. There's marrow that's associated with it. The marrow is important. You'll have to discuss this later on when you talk about, well, where did the blood cells come from? All blood cells originate from their precursor cells from the bone marrow. So blood, of course, is associated with it. A blood supply to the tissue. So since it is a dynamic tissue, it needs its own blood supply. Cartilages, of course, are associated with it, and then there's an outer connective tissue covering, fibrous connective tissue, that covers over the outside of the bones that's called the periosteum. The periosteum. So this is the tissue that wraps around, hence the term peri, around what? Around the bone tissue itself, or the osteo consistency of the tissue. So with the cartilages, there are two types of cartilages that are associated with the osseous tissue. Of course, ligaments are going to hold bones together. So bones are held together at the bony joints by ligaments. The muscles will attach to the skeleton using the tendons. So a muscle will always pull at a bone. The bone will act as a lever system, and we have motion or movement of the body. Again, as a dynamic tissue, there's a nerve supply, so there's nerve innervation. It hurts if you break a bone. There's also bleeding that can occur out of the bone because there are blood vessels that are associated with the osseous tissue itself. So it allows it to both be a sensitive tissue, but also be a metabolically active tissue. So what are the functions of the skeleton? Most people out on the street know that it's there to support the body. They know that muscles are attached to it and that we have movement or motion in the body because the muscles pull at the bone. Most people also would probably know that it is for protection. So most of your vital organs are housed within an area encased by bone. So in the brain, of course, it's enclosed by the cranium or the skull. The spinal cord enclosed by the vertebral column. The thoracic cage encloses the lungs and the heart. So the heart is held behind the sternum or the breastplate. So it is a major protective function for the body. We've already mentioned that along with support, it's also for movement. So attached to muscles, it's going to allow for movement of the body. It allows for the thoracic cage to expand its volume, and we inhale. The volume starts to decrease in the thoracic cavity because of loss of muscle action, and the ribs literally come back in and it forces air out of the body. So breathing is one of those movement types of functions. It also, because of the calcium and the phosphate ions that are associated with the calcified matrix, it lends itself to work with homeostasis of electrolytes. So electrolytes start to maintain their balance because of the skeleton. So if the blood is lacking in calcium, a lot of times the body will break down the osseous tissue, release the calcium or the phosphate ions into blood circulation. Also, usually we have the calcium carbonate acting as a buffer, so that's going to influence your acid-base balances. So if you're going too acidic, a buffer like sodium bicarbonate can bring it back up to a more neutral level or a more homeostatic level. Then we've already mentioned that the marrow itself is for blood formation. So the bone marrow, especially in the middle of your long bones, or the epiphyses of your long bones, and the middle of your flat bones, is where you're going to have your bone marrow. And that marrow, of course, will make all of your formed elements that are in the blood. So that would be your red blood cells, your white blood cells, and also the precursors to your platelets. The next screen tries to classify the bones based off of their shape. So many of the bones are in the category of either being long bones or short bones. So notice that long bones are longer than they are wide. These, of course, are the ones that are the major levers in the body. When muscles that are very strong attach to these bones, we can lift heavy objects, we can move in various actions with the overall body. Short bones are equal in length and width, so that would be something like the carpals in the wrist. Those are usually a little bit more flat, so they start to glide over one another, and it allows to move the body in multiple directions around that particular joint. So both your carpals in your wrist and your tarsals in your ankle are considered to be short bones. Flat bones would probably be the third largest class, because these are the ones that, of course, are going to be flat in shape, and these are the ones we mentioned that usually cover your soft, delicate organs, that it's very vital to keep the integrity of that organ. So it says they're curved but wide and thin, and their function is to protect the soft, delicate organs. So that, of course, would be the scapula, protecting the back part of your pectoral girdle. Your sternum, I've already mentioned, is where directly behind that, more deep to your sternum, you have the heart. So for protection. The other group, the fourth group, which is the class of irregular bones, these are bones that don't fit in any of the previous three categories. So these are the ones that have these weird or elaborate shapes to them. And one of the most awkward of all bones would probably be the sphenoid that it shows you in the diagram. The vertebrae, because of the different processes on them, like the spinous, the transverse processes, and the superior articular facets, allow different shapes and a variety of shapes to come about. But the sphenoid still is probably the most elaborate of all the shaped bones, with all the pterygoids and the wings to it, which would, of course, cause it to be fit in the class of irregular bones. If we look at the structure of the flat bones, notice that the textbook describes it as being a sandwich appearance. So you have the spongy bone in the middle, comprised by two layers of compact bone. So that would be like a sandwich. The spongy bone would be relative to the meat, and the compact bone relative to the bread of the sandwich. So the two layers enclose that middle layer of spongy bone, so that you have a lot less weight, especially to the skull, having that large layer of spongy bone in the middle and it not being solid bone all the way throughout allows the skull, the cranium itself, to be much lighter. But it's still, because of the makeup of it, notice that you have the framework, and we've already said the framework that runs through are called trabeculae. So the actual struts or the framework of it are called the trabeculae, and remember that you have the open areas of the spongy bone, and that is where the marrow is going to be. And notice that we call this layer of spongy bone that's sandwiched in between two compact bones, we called it diploe. So you have this vocabulary term that refers to the cranium being layers of the spongy bone, trapped in between two layers of the compact bone to absorb shock, and also again allow the marrow spaces that are lined with endosteum to allow the blood to collect in those areas. The irregular bones we already said have elaborate shapes. We've already said the vertebrae, especially the atlas and axis. Remember, those were the two exceptions to the cervical vertebrae. They each look very distinctive from one another and the rest of the vertebral column. We've already said the sphenoid bone was also very irregular, but remember also the ethmoid bone was, with that huge perpendicular plate extension out of it. I told you in lab that you were responsible for the structure of a long bone, because we're going to get into it, talk about the different parts in this portion of the lecture. So you have some areas that you can be familiar with. You have the epiphysis on each end. You have the diaphysis, also known as the shaft. And notice where there's areas of both compact bone and then there's areas of spongy bone. So notice at the ends of the bone you have the red bone marrow and spongy bone. Compact bone is of course on the outside. The marrow cavity is important. So you have in the diaphysis or the shaft you have yellow bone marrow, but in the epiphyses you have red bone marrow. And remember, the red bone marrow we're going to talk about a little bit later makes the blood cells. The yellow bone marrow is going to store the fat or lipids. Notice on the ends of the bone we're left with a layer of cartilage, and this was from the leftover remnants of the hyaline cartilage that the whole skeleton first came from, is known as articular cartilage. So the hyaline cartilage, if I could spell it, the hyaline cartilage that's left over is now known as articular cartilage on both the proximal end and the distal end of a long bone. And then again we have this layer of fibrous tissue that covers over on the outside, wraps around the entire length of the bone, and that's known as the periosteum. So again, the notes get into some general features. We've already said that the outer shell of the bone is compact. It's much more dense than the spongy bone. We said the shaft was known as the diaphysis. The medullary cavity, also known as the marrow cavity, is in the diaphyses of the long bone. The epiphyses, remember, is the enlarged ends. So it says that this is most of the time where the ligaments and the tendons are going to attach to the bone. We said the spongy bone, of course, is covered by the durable compact bone, but it gives, again, less weight, but still the same structure. We said the leftover cartilage from hyaline was articular cartilage. And then, of course, because it is living dynamic tissue, it has to be nourished, so you have the nutrient foramina. Remember, a foramen is a hole in the bone. So you have these minute holes or nutrient foramina that are going to allow the blood vessels to get into the tissue, penetrate deep into it, so that it can be living dynamic tissue. We said the periosteum was a fibrous layer. You have the collagen fibers that are there. You have an inner osteogenic layer where you're actually going to have new bone forming cells. So it says that this, of course, is important for growth and healing if you ever break or fracture a bone. The endosteum, we said, lines the marrow cavity. So this is cells that house the endosteum that can actually dissolve the ossified or the calcified matrix, and then others that are there that will deposit new matrix. So having some of the tissue dissolve while new tissue is laid down is going to allow for the remodeling of the bone. And then you have something called the epiphyseal plate, also known as the growth plate. So again, hyaline cartilage is what the entire skeleton was developed from. That was the model as how the skeleton was laid down, hyaline cartilage. So the hyaline cartilage that separates the marrow spaces between the epiphyses and the diaphysis is considered to be the growth plate or the epiphyseal plate. So until you go through the end of puberty, you grow in length, and we'll talk about how that happens later on. but the epiphyseal plate is there. Once it closes off and you're as tall as you're going to be, so it depends on the individual, but it depends on which sex you are, anywhere from 18 to 22 years of age, then what you're left with is scar tissue that's known as the epiphyseal line. So in an adult, all you see is a bony scar that once marked, or that does mark where once you had the growth plate or the epiphyseal plate. So again, you have the figure to label the basic features and structures of a long bone. The next section gets into the histology of the bony tissue itself. So of course we've already classified bone as a connective tissue. So most connective tissues, remember, had a predominant amount of fibers associated with it, cells were consistent with it, and you had ground substance or matrix in the background. There are 4 different types of bone cells that we find in histological preps or in the histological study of it. We have the osteogenic cells, we have osteoblast with a BL, we have osteocytes, and we have osteoclast. So the term osteon refers to, or osteo refers to bone. Cyte, of course, means cells. Anytime you see a blast cell, blast are going to be bone forming, or they're going to form the new tissues. Clast with a CL are going to be dissolving types of cells. So let's start with the 4 principal types. The first one on the bottom of the screen is the osteogenic cells. So these are the stem cells. These are the ones that are found scattered throughout the endosteum, the periosteum, and also within the central canals of the tissue. So embryologically, this was your mesoderm or the mesenchymal cells. So these are undifferentiated stem cells known as osteogenic cells. These are the ones that are responsible for multiplying and producing new cells, which would be osteoblast. Notice with osteoblast, these are bone forming cells. So notice the textbook says that they line up as a single layer directly underneath the endosteum lining the marrow cavity, or the periosteum that's wrapping around the exterior of the bone. These cells themselves are non-mitotic, so they're not going through cell division. They are responsible for synthesizing the soft organic matrix that will eventually harden once the calcium and the phosphate ions come in and you have the mineralization and bone deposition. So stress and fractures would cause osteogenic cells to multiply rapidly. They would increase in number and produce osteocytes that would reinforce that area of injury or area of stress and be able to rebuild the bone, remodel it. So osteoblasts are the bone forming cells. Then we have the bone cells themselves. So these were once former osteoblasts, but this time they become trapped in their matrix. So remember, the osteoblast has laid down matrix all around them. Now they're trapped in their lacunae. So now they are referred to as osteocytes. Former osteoblasts that have been trapped in their own matrix that they once deposited. So the lacunae, remember, are the little indentions or the little potholes that allow the cells to reside in. Notice again, we've talked about before that because the matrix is calcified, it's hardened, it's going to be very hard for soft tissues like blood vessels and nerves to penetrate back and forth. So the way the cells will communicate with one another is using these little thoroughfare channels called canaliculi. So these are actually going to spread out from each lacunae so that one would connect in one layer with lacunae in the next layer. So the osteocytes will have little cytoplasmic processes. So these are little extensions of the cell that reach deep into the canaliculi, and they allow then the osteocytes to reabsorb some of the matrix while others that are in the area can deposit it. So it's these actions of all these different cells that contribute homeostatically to how the bone will either dense up or lose its density, and how fast or how slow the calcium and phosphate ions are brought in to either build up the bony matrix or to tear down the bony matrix. So notice it says when a bone is stressed, it produces these biochemical signals, and these signals are going to be sent out so that the bone will start to remodel itself. The other group of bone cells are going to be the osteoclast with a CL. So these are the dissolving cells, the bone dissolving cells that are found at the surface of your bones. So notice that these develop from the same bone marrow stem cells that also give rise to your blood. So you have the formed elements in the blood that is the same tissue that is going to give rise to osteoclast. These are of different origination than the rest of the cells that are forming and we've considered as bone cells. Notice that osteoclasts are unusually large cells. It's where several stem cells have fused together, they've come together, so you usually have many nuclei. It says you can have up to 50, but usually around 3 to 4, so multiple nuclei. They also will start to fill in something called the ruffled border. So the side of it that faces the surface of the bone has this ruffled border to it. So notice it's described as infoldings, deep infoldings where the osteoclast membrane will indent in to increase the surface area of the cells and also allow it to reabsorb the matrix that it's dissolving, and that reabsorption will be efficient. Also associated with the osteoclasts are these reabsorption bays that are pits. Notice these pits occur on the surface of the bone where the osteoclasts are formed near the surface of the bone. So overall, the osteoclasts are there to remodel. It's the combined action of these doing the dissolving and then the osteoblast doing the depositing. So you have osteoblast and osteoclast that are responsible for remodeling. And the figure in the book shows you that the stem cells, remember, they're undifferentiated, but then they start to form osteoclasts. The osteoclasts then reside. Here you have the periosteum, outer covering on the bone. They reside with the ruffle border facing inward. The reabsorption bays are these extensions of the membrane, so that secretions from the cell and the matrix will have plenty of surface area. And then it also shows you in the picture that you have the osteocytes, or the bone cells, that are in their lacunae, and then you see the canaliculi that extend out. So it's almost like you have the osteocyte housed in a lacunae, and then out of the lacunae you have these extensions or canaliculi. So it sort of looks like, someone said once, it reminds them of like a spider. Considering the matrix, again, by weight, it's about 1/3 organic, 2/3 inorganic matter. The organic matter is, again, our collagen fibers we've talked about before. You have these carbohydrate protein complexes that we'll mention a little bit later on, these glycoaminoglycans, proteoglycans, and glycoproteins that form the organic side of it. Remember, organic compounds have carbon skeletons and usually hydrogens attached in various places around the carbons. But notice, for our intents and purposes, I believe you have an objective that asks you about the inorganic matter. Notice that 85% of it is something called hydroxyapatite. So this is your crystalline calcium phosphate salt. And then 10% of it is calcium carbonate. Remember, calcium carbonate can act as a buffer. There are other trace minerals that are there, so fluoride is important to help strengthen it. We see this with the dentist. They give you fluoride treatments to strengthen your teeth. Sodium and potassium and magnesium, those ions are associated with these calcium phosphate salts. So again, that's why we said the electrolyte balance can be either maintained, buffered, or they can be sent into abnormal values because of the breakdown of the skeleton. So notice, though, that bone is considered to be a composite. Two different structures to it. Portions of it are a ceramic. If you know anything about ceramics, that would be something like your dishes or bowls around the house that if you drop them on the floor, they very much shatter. But if they're sitting on a table, they could hold cereal, they could hold, any types of material as long as they have their integrity, but they're very much fragile. The other portion of it is a polymer. So notice that it says that the way that nature allows the matrix to combine in the bone tissue, it gives the optimum of both of the properties. So each one has mechanical properties that is lacking in the other component, but together the ceramic portion, it says, allows the bone to support the body weight, so it gives it strength and resilience, but the protein portion of it, which is the polymer, gives it some degree of flexibility so that your bones just don't shatter, hopefully. There are some conditions with the skeleton where the matrix does change and there's not a lot of protein that's there to form that polymer, and it becomes more of a ceramic. So slight pressure on those bones do allow it to just shatter like glass would or a ceramic bowl. So again, we need to look at the figure of the histology of the compact bone. So notice again that it reminds you of the tree ring. You can see the central canal. We've talked about the canaliculi that extend out, so it shows you that in the figure. We talked about the little pits in the matrix called lacunae, and then you see layers and layers and layers of the osteocytes laid down in their lacunae, and that's referred to as the lamella, singular, or lamellae plural. With the compact bone, it's centered, and go back to the figure. The figure actually shows you, this shows you one osteon. So a Haversian system, that was the old name, is now referred to as an osteon. This is the structural component of the histology of compact bone. So you have the central canal at its center point, and then around the central canal you have layer after layer after layer, like an onion, of these lamellae, where the matrix has been laid down, it's calcified and hardened. And we've already said that each of the concentric lamellae can now connect from one another because you predispose these little canals or tunnels called canaliculi. So each cylinder of tissue around the central canal becomes arranged in the osteon. Associated with it are something called perforating canals. So if you look at the model, you actually see these transverse, or sometimes it goes diagonal, passageways along the length of the osteon, and this of course is where you're going to have your blood vessels and your nerves that connect from one osteon to the other. It also goes longitudinally up and down lengthwise to connect the whole osteon and all of the lamellae that are associated with that particular central canal. You can also notice the collagen fibers. Remember, the thick protein fibers made of collagen will corkscrew down the matrix of the lamellae. Each one will alternate out. So in one way they would alternate to the left, in one way they would alternate to the right. So it's easier to see that on the model in the classroom of the corkscrew collagen fibers that will form a helical arrangement around one lamellae, and the opposite direction would take place in the next lamellae. So having the collagen fibers, we already know that these are the strong protein fibers, allow that osteon to be very strong, and it gives added strength to the entire histological tissue there. Again, we said it's dynamic, so of course you have to have plenty of blood flow to it. We said the nutrient foramina allow the blood vessels and nerves to enter into the bone. Not all the matrix is actually in an osteon. There are also lamellae that are laid down around the entire boundary of the dense bone. So inner and outer boundaries of the dense bone. These are called circumferential lamellae, and you can actually see these as they run parallel to the bone surface on the model in the classroom. There's leftover lamellae that are not actually part of an osteon. They're not part of circumferential lamellae, so we call these interstitial lamellae. So these are the remains or the leftovers from old osteons where the bone itself has remodeled, it's grown, and the extra lamellae are left over. So they're referred to as interstitial lamellae. So in the figure you can see the diagram. We gave you that. We said the model in the classroom also shows you the same structures that are there. With the spongy bone, we've already said it looks like a sea sponge. It has the slivers of bone called spicules. The thin plates that actually give it structure and form are called trabeculae. And then the spaces that are open are the spaces, the marrow cavity that's filled with red bone marrow. So the trabeculae are not associated with central canals because the marrow cavity nourishes them. They do have very few osteons. All of the osteocytes, though, are in association with the bone marrow so they can receive their nutrition. So spongy bone, we've already said, allows strength to be given to the bone structure, but there's not a whole lot of weight added to it. You do see more trabeculae, though, develop in lines of stress where spongy bone is associated with that area of the bone, especially like in the epiphyses of your long bones where they're under great deals of stress. Extra trabeculae are laid down in the spongy bone in those lines of stress. So the figure in your book shows you several areas, and this is the femur. How do I know? Well, you have this almost, we said, hemispherical head, very long surgical neck to it, and you have the greater trochanter that's shown there. So those are areas where someone falls, especially your geriatric patients, on the hard floor in the hospital, and it's very easy for the neck to slap off of the femur, and you can see why with the major stress lines that go through the compact and the spongy bone in this area. We said the bone marrow is found within the medullary cavity of long bones and among the trabeculae in spongy bones. So you need to know that red bone marrow makes your blood cells, your red blood cells, and your other hemopoietic tissues there, your other cells like white blood cells. So you find red bone marrow especially in the vertebrae, the ribs, the sternum, the hip, the proximal heads of the femur and the humerus. So if they're going to do a bone marrow extraction, a pathologist that's trying to diagnose some types of blood cancers or certain other types of cancers will do a bone marrow extraction, and they are usually will try to pull that from the sternum, the hip bone, or one of the heads, the proximal heads of either the femur or the humerus. Notice the yellow bone marrow contains the fat. So in adults, you have fatty marrow known as yellow marrow. As we age and we get into the geriatric years, the yellow marrow becomes replaced by a gelatinous marrow. So this is, according to Dr. Saladin, described as a reddish jelly-like consistency that once was the yellow fatty marrow of the long bones.